name's Phil McEwen. I'm the Chief Executive of a research agency called Health Economics and Outcomes Research Limited. We're based in the UK. We spend most of our time trying to understand whether or not the use of new health technologies represent good value for money. A lot of that is directed towards to payers, but interestingly, there's the concept of value has merit across the healthcare system. So we spend a lot of time looking at value from the perspective of patients, society, clinicians, providers, and so on.
This is Goretti Mallorquí. I'm a scientist also from my background, from education. I got a bachelor degree in biology, then I did my PhD, and I'm currently working in a research center, Valdebrón Institute of Oncology. And also on top of that, I have diabetes for 45 years, so I've been always involved in other projects that helping, that my contribution can help to the monitoring or providing support. And I did 4 other European projects. I'm also part of the patient advisory network from the company which made the insulin pump that I use.
My name is Taddei Battilino. I am a physician trained in pediatric endocrinology initially, and then focused for the last 30 years on different aspects of diabetes technology, and novel treatments. We believe that real-world data have several advantages beyond randomized controlled trials. Of course, we need a randomized controlled trial to understand the real effect of a certain compound or technology. But then we also need a broader access to assess safety, and also to assess whether people with diabetes are happy with the therapy provided to them. And finally, this can also broaden the access to these medications to many other people, because it can speed up the required information on a certain medication or technology.
I would say that for us, for the people living with diabetes, it's of course is a key tool, but because we live around data and we generate data every day, and we need to registry since the beginning, if we think about 40 years ago in papers, but now what I see most powerful is the change. We are in the technology area, we have like artificial intelligence helping us to also to monitor and to extract information, so it's crucial to have the information, but it's crucial because we need it to manage our disease, and not only ourselves, our physicians, the scientists, the research community. So it's essential to be able to extract even more information from this data and to interpret, to analyze. Of course, then we need the minds and the researchers working there. But of course, it's essential for us as our daily life, and also for the stakeholders from the health care system, and for the scientists as well.
We spend a lot of our time trying to hunt out data. It's for very good reasons. There's a lot of necessary restrictions and ethical considerations around accessing confidential patient-level information. But as researchers, what we really want to do is to be able to do the best research we can, and having access to patient-level data is crucial. Now, whether it's trial data or whether it's observational data, it doesn't really matter. There's nothing worse than the modelling at the mean. So doing analysis and trying to provide insight to people that are making decisions in healthcare using data that is not as rich as it could be is quite frustrating. So one of the opportunities for the use of synthetic data is the ability to be able to capture some of those rich interrelationships that exist within patient-level data without some of the concerns around confidentiality and so on. So I think whether it's to do with forecasting and modelling projections in relation to the disease or the outcomes, the use of synthetic data is tremendously powerful, and I think would help the availability of standardised data sets that researchers could access and benchmark against. Again, would be really helpful. It would help to reduce an area of uncertainty that exists in decision making that's potentially unnecessary. So if we could achieve the use of synthetic data in that context alone, I think it'd be a huge step forward.
We know this from many other subspecialties, particularly cancer and rare disorders, where registries are well established. So we do need good registries in diabetes. There are many in type 1 diabetes, but in type 2 diabetes they are lacking all over the European Union and probably other developed parts of the world. They're crucial because they help us understand the longitudinal progression of a disease and also progression of people with this disease. So it provides us with information that is unique, different from whatever we gather in trials, being randomized or observational.
I mean, in diabetes in particular, I think real-world evidence is incredibly powerful and necessary. The clinical trials, doing a superb job at the very specific task that they're designed to do. But with diseases that involve such levels of complexity in the sense of engagement with the care, lifestyles, fitting in therapy regimens around family, work, commitments, etc., different stages of people's lives and so on, those aspects have such an impact on the outcomes that can be achieved through through the management of diabetes, and those things just aren't well suited to capturing within a clinical trial environment. And so the ability to be able to supplement what we know from the trial into what can potentially be realized in clinical practice is incredibly powerful, and that's real-world evidence. In addition to that, the need to be able to understand how the incidence and prevalence of diabetes is likely to change over time as the populations in the various countries evolve through patterns of migration and obesity and aging, socio-demographics, all of those factors are incredibly important to understand what the likely burden is going to be in future years. And so the impact of that on the disease, the impact that patients have, the impact that it has on society, on work, on the environment and so on, they're all factors that are only really addressed or can be addressed through the use of real-world evidence. So I think it's not trying to downplay the importance of clinical trials, but actually they do a very, very, very good job at a very specific task, but everything else is real-world evidence. For some of the items that we've kind of covered already, I think the primacy of the clinical trials is obvious, but there are so many other factors that exert such an important influence over the outcomes that can be achieved in diabetes that I think the ability to be able to broadcast and communicate what those challenges are and what some of the potential solutions are, you can only enhance diabetes care. And I'm thinking back to the days when 20, 30 years ago it was all about glucose control, and then people started realizing what hypoglycemia could do to diabetes management, and now weight gain, and there's that evolution of insight is something that's only really addressed through all the different avenues that the REDDIE project is considering. So I think it's it can only have a positive impact.
I think it's good, of course very good, but also because this need to maybe standardize, homogenize, harmonize, to be all on the same page, especially if we think about the fields of researchers working on the same field, because of course I would say that is important nowadays also the personalized medicine and to be able to go case by case, but in order to reach that point you need also to manage and to evaluate and to validate lots of data, big data. So then it's important for that, because if you work in an European environment, you can just help among the countries and among the institutions, and the registries, of course, thinking about the European level. So I think it's nice and wonderful that there are projects as REDDIE working on that.
REDDIE, as a European Union funded project, is uniquely positioned to really develop and then promote the help of registries and also artificial intelligence to help us use these registries more efficiently. I believe that artificial intelligence will help us gather much more data with a higher accuracy, and would also perhaps spare some burden from people with diabetes, because perhaps at some point synthetic participants in trials can partially replace or add to the existing real participant data. So I believe that the tasks, the work packages of REDDIE have all the advantages that need to be pursued in the near future. The efficient gathering of data, efficient analysis using artificial intelligence, and then the real usage of this data to speed up and broaden access of modern medications and technologies to a broader mass of people with diabetes.